These are my disclosures. I have to add one more disclosure. Preparing a lecture on switch is like buying a computer. The moment you start using it, it's already old. So I apologize for any missing data that I have not included here. So the first thing is, why would you do that? Why would you switch a patient that is already okay? The patient is virologically suppressed, he is happy. So we have heard several times, don't fix it if it's not broken, except if you want to improve adherence, if you want to reduce pill burden and dosing frequency, if you have to address issues like tolerability or toxicity, if you have a regimen in which you have food or fluid requirements, which seems a little bit old, fluid requirements is no longer an issue, but it used to be in the old Indinavir times. If you want to reduce the chances of drug-drug interactions, to adapt the regimen to pregnancy, as we heard today, to adapt regimen to aging patients, and to reduce cost. On top of that, also you might find some concerning laboratory values that you would like to modify. You might be concerned not about short-term toxicity, but long-term exposure to drugs that at the end of the day might do some harm to your patients, or just you want to simplify your therapy. And nowadays, HCV treatment has come across in co-infected patients as a reason to change regimen. So who should be switched? And I want to give you a word of caution. As we have seen in some of the study that has been presented today, the question is, how long has been your patient suppressed? Short-term suppression might be a kind of recipe for failure. Has the patient failed former antiretroviral regimens, even if he's undetectable now? Who is asking for a switch? Is this a question coming from the patient? The patient says to the doctor, well, you know, I'm not happy with my regimen, I want to change, or it's you. It's the doctor. We try to be in some way a la mode and say, okay, it's time to switch. And you need to answer the question if this is an urgent switch or is a strategic switch. I mean, an urgent switch could be you have a patient, let's say, in nevirapine and LFTs go up, and then you need urgently to switch. Strategic switch would be a patient is okay, but then you think that it would be better to have a new regimen. So how do you do this? Well, first, and as highlighted in red, the main thing you cannot sacrifice is the potency of the regimen. Is the new regimen at least as potent as the current one? It could be better, but is it at least as potent? What is the genetic barrier of the new regimen? Is tolerability improved or at least maintained? Are there no toxicity concerns? Again, treatment history is carefully considered. Is there any resistant history? And the patient knows that new side effects might develop, as in any change. The patient is doing okay, he has been treated with X regimen for 4 or 5 years. You introduce a very good regimen, but it's a new drug, and so new side effects can happen. And the patient agrees and takes ownership of the change. It's not only that you decide, but the patient agrees on that. So you have a menu of switches. If we are talking about modifying nucleoside reverse transcriptase inhibitor, in some cases you have to do it now. If you still have a patient on D14 DDI, please leave the room and change it now. If the patient is on CDV, then you have to proceed shortly. You can stay until the end of the session and phone your hospital. It might be that you need to replace TDF basically for renal issues. I'm talking about the classic tenofovir. Or you have to replace abacavir because the issue of cardiovascular risk, which still is controversial, but I wouldn't be happy with a patient coming out of the intensive care unit and being still on abacavir. You might wish to modify non-nucleosides, and you might wish to replace efavirenz because of the very well-known CNS side effects or lipids, or to replace nevirapine, basically not because of toxicity, because toxicity for nevirapine is a kind of early phenomena, but a patient might be a little bit tired of having a BID dosing. And you would like to modify PIs due to tolerability issues or lipids or drug-drug interactions or any of the combination of these three elements. So you could delete ritonavir, and this can only happen with atazanavir. You can switch from a BID regimen to a QD regimen. You could switch to NNRTIs or to integrase inhibitors. You could switch to PI monotherapy, to PI plus 3TC, or switch to integrase inhibitors monotherapy. So let's have a quick review of some studies. For instance, switching from abacavir 3-TC to tenofovir FTC, as you can see, patients are undetectable for at least 3 months without any prior resistance. Patients are randomized either to tenofovir FTC plus a boosted PI or abacavir 3-TC plus a boosted PI. And as you can see here, you see that there is 86% of patients at week 48 undetectable with tenofovir and 83 with abacavir 3-TC. But when you go to true virological failure, you see more virological failures in patients with abacavir 3-TC. Of note, if you look at the bottom of the slides here, you will see that the percentage of patients that discontinue study drug due to an adverse event was higher in the tenofovir FTC group. What does it tell us? That tenofovir is such a bad drug that produces a lot of discontinuation? No, the patients were okay in abacavir. You switch, you might have some advantages in terms of virological failure, but you are exposing your patient to a new drug, so some adverse events can come across. Obviously, there are benefits in terms of lipids. As you can see, tenofovir is a kind of protective drug in terms of lipids. So switching from FTC tenofovir to 3-TC abacavir maintained virological suppression, had fewer virological failures, but elicited more adverse event-related discontinuations with slight declines in eGFR. On the other way around, switching from tenofovir to abacavir in patients that are showing some disorders in renal function, and this was presented by Julio Montana's group in the International AIDS Conference in Durban lately. And as you can see, the patients that switched from tenofovir to abacavir-based regimens got a significant improvement of serum creatinine, eGFR, etc., maintaining plasma suppression, very low plasma suppression. Then you have a switch from tenofovir to TAF. This has been shown in several studies. Basically, the message here is that you don't lose potency moving from tenofovir to TAF. You preserve potency. There is no risk of further virological failure. And then we change gear a little bit and we go to non-nucleosides. So here is a study that switched patients from efavirenz to etravirenz in patients with CNS adverse events. And keep this in mind, because at the end of my talk I will make the point about why is it legitimate to switch and when. And in this case, it seems that it sounds logic. Patients that have already CNS adverse events were randomized either to continue with efavirenz or to switch to etravirenz in a randomized placebo-controlled trial. And as you can see, significant reductions were seen in overall adverse events, 89% versus 60%, and this applies to insomnia, abnormal dreams, and nervousness, without any risk in regards to viral load or CD4. So the switch in this case, I think, is absolutely justified. The SPRIT study switched patients from ritonavir boosted PI to the combination of tenofovir, FTC, and rilpivirine, and as you can see, patients that were stable. It's almost the same story. Stable patients, undetectable viral load, without resistance, etc., were randomized either to a rilpivirine-based regimen or to continue with 2 nukes plus a PI. And at week 24, everybody was switched to the experimental arm. As you can see here, in terms of virological efficacy, non-inferiority was shown even in the group that has more than 100,000 copies. So really, this strategy seems to work. Also, if you look at the other interesting points like lipids, there is an evident benefit when you move out from PIs to a rilpivirine-based regimen. And the same holds true for, in general, lab abnormalities, as you can see here in the bottom of the slide. It's a little bit difficult to move this, but you can see it. There is another paper recently published in which patients were switched not from a boosted PI, but from unboosted PI, in this case atazanavir, to a single tablet regimen containing rilpivirine, and as you can see, there's a evident benefit in terms of cholesterol and triglycerides. So even when you compare a non-nucleoside like rilpivirine to unboosted atazanavir, there is an advantage in terms of lipids. Then we have the Jose Arriba study, the Monet study, in which patients were randomized either to continue with darunavir, ritonavir, plus 2 nucleosides, or to be exposed only to darunavir, ritonavir 800-100 QD. Patients were adults, were darunavir naive without any history of virological failure and undetectable for more than 6 months. And as you can see here, if you look at the first part here, you will see that darunavir plus 2 nucleosides darunavir monotherapy underperformed the triple drug regimen. But if you take switch as part of the strategy, that means that patients that are failing with darunavir monotherapy can be reinduced with 2 nucleosides, then non-inferiority is shown. So majority of the patients will do well with the PI monotherapy. Some patients will need that you reintroduce the two nucleosides as a strategy. A paper that is in process to be published studied the same phenomena with darunavir and lopinavir, and found that in terms of virological failure, only one patient in lopinavir ritonavir showed this showed virological failure, and patients exposed to darunavir, none of them showed it. So this strategy is still under consideration, and I know that in Europe many people still use PI monotherapy as a switching strategy. The pivot trial was a really interesting study that was published late last year. It randomized 587 patients, and the main message here for protease inhibitor monotherapy as a switching strategy showed that in monotherapy they had a little bit more viral rebound, but resuppression was achieved. Exactly the same findings that Jose Arriba had in the Monet trial. So non-inferiority in the pre-specified switch strategy included was shown. Together with Sharon Wamsley and other colleagues, we did a systematic review that was published in PLOS ONE last year, in which we looked at naive patients and previously experienced virologically suppressed patients. This graph that I am showing is addressing only the topic I am talking about today. That means switch strategies. As you can see, at that point in time, those were the published studies. I will address studies that were published afterwards, after our publication, but only 2 studies with the arrows, the SALT study and the NECA study, compared exactly the same strategies plus minus a third drug. The other ones either were only a one-arm study, like the study by Calza, the second one here, or they compared darunavir, raltegravir versus lopinavir, ritonavir, and TDF-FTC. So it's hard to draw any conclusion. In the SALT study, non-inferiority was shown, and but in the NECA study, there was a difference in favor of lopinavir, ritonavir. So the conclusion of our paper at that time that there are potential benefits of dual therapy, but still large randomized clinical trials are needed in order to firmly establish this advantage. The OLE study, again by Jose Arribas, who is very active in this field, compared lopinavir, ritonavir BID plus 3TC or FTC, or lopinavir, ritonavir BID plus a combination of 2 nucleosides, including 3TC or FTC. And it's very easy to see here that either you look at protocol-defined virological failure, any blips, or the combination of both. There's no difference between arms. So as a simplification strategy, in the OLE study, randomized clinical trial with enough power to show it, there's no difference. Recently, François Raffi and colleagues published the kind of systematic review about studies addressing simplification to INIS. And as you can see, switch mark spiral strategy, PI strategy, non-nucleoside striving, and the 0109 study were included in this analysis. So the switch mark study is a very good example of a case of failure. When you prepare something in the wrong way, you will obtain a bad result, and this is exactly the case. So what was done here? Patients that were on lopinavir, ritonavir plus 2 nukes were randomized into raltegravir BID plus the nukes, or lopinavir BID plus the nukes they had. So what happened was very good for lipids. Lipids improved a lot, as you can see here, triglycerides mainly, also total cholesterol, etc. But when you go to viral suppression, it was not that good, and they were unable to show non-inferiority in this trial. So the strategy of simplification to raltegravir from PIs seemed to be dead. But a better designed trial with exactly the same drugs, boosted PIs plus other ARVs, or switching to raltegravir BID plus other antiretrovirals, by taking care that the patient should be at least 6 months undetectable without previous failure, etc., then the results were good for lipids, as we saw in the switch mark, but were also good in terms of virological suppression. So as you can see, that patients had between 86 and 89% efficacy. So it is highly dependent, the success of your switching strategy is highly dependent on the type of patients you select for that. Regarding elvitegravir, as you can see here, there was the strategy PI in which patients that were on PIs were randomized to receive either elvitegravir-based therapy or continue with the PIs. And as you can see here, non-inferiority was shown, and there was an improvement in patient-reported outcome regarding GI disturbances and satisfaction scores. So indeed, if you look at strictly and from statistical point of view, it looks like it was even better to switch to elvitegravir. So in terms of statistical superiority can be claimed, which is not the case with the non-nucleoside based regimen, in which patients were randomized to continue with non-nucleosides or to switch to elvitegravir, in which non-inferiority was shown. As you can see here, the 95% confidence interval crosses 0. So improvement again was reported basically in neuropsychiatric symptoms compared to baseline. The striving study was a study in which patients were switched from suppressive heart to a fixed dose combination of dolutegravir, abacavir, and 3DC. And this was published this year, in which patients were again randomized either to receive the experimental arm or to continue with the baseline IRT until week 24, and then they were switched to the experimental arm. And as you can see here, both in early switch and in late switch, the results could show non-inferiority. There were no cases, almost no cases of virological non-response, and the satisfaction score was much better in patients with a new regimen. Then we saw a lot of information regarding LATE2, so I will not spend that much time in this, except for stating that this is a study in which in the induction phase patients received oral combination of abacavir, 3TC, and cabotegravir, but in the maintenance phase patients were randomized either to receive orally or to receive every 4 weeks or every 8 weeks injectable intramuscular the combination of cabotegravir and rilpivirine. And as you can see here, the virological success rates were around 90%. Virological non-response was a little bit higher in the Q8 weeks, so this strategy is no longer being explored. But for 4 weeks, it was absolutely comparable with the oral regimen. If it comes to analyze the satisfaction with intramuscular and oral regimens, you can see that satisfaction was eventually higher in patients that are exposed to intramuscular injections. Then it comes to the conflictive point of dolutegravir monotherapy. I was talking with Jose during the break. How much do you want to stress the potency of a drug? Dolutegravir is very good in triple therapy. We are testing it in double therapy and immunotherapy. But in monotherapy, in any case, well, in this particular paper from Moreira recently published, is a kind of systematic review of trials in which dolutegravir monotherapy is being used as a switch strategy. And as you can see here, it's 91.9% efficacious. But we are talking about patients that were already undetectable. So we are losing about 9%, 8% of the patient. So is it worthwhile to take that risk? My take is we should be very careful when we are trying this type of strategy. The dolu-mono, not to be confounded with the do-mono that we saw recently, names are similar. It's a retrospective study with 31 patients, and again, 94% remained undetectable. But one patient had confirmed virological failure, low levels, that's true, 538 copies, but with new integrase mutations, the 148 and the 140. So again, I think we need a note of caution in exploring dolutegravir monotherapy in patients that are already suppressed and they are doing well. So our scientific appetite should be a little bit tempered with the patient's benefit. And this, I think, it's a very important paper in which they are showing the quality of life of HIV patients who switched antiretroviral medication due to side effects or other reasons. And if you look at the light gray bars, they are highlighted with a red sign. Those are patients that really, they changed therapy because they had side effects in their original regimen. And yes, quality of life improved. If you go to the dark bars, patients that switched for other reasons, so they had not complained with the prior regimen. Look, guess what? There's no improvement in quality of life. So are we doing the right thing, switching everybody at any time, or do we have to select those patients that really are complaining about the current regimen, or there is a medical reason for that? Oh, sorry. Here we go. And as I told you, there are a lot of studies coming. So during this week, we will see data on atazanavir 3TC. In the Atlas M study, we will see data on PIs plus 3TC, TAF plus darunavir-CoV, TAF plus rilpivirine, 96 weeks data on TAF, dolutegravir monotherapy in the DOMONO study that we see some information today, and the dual darunavir-ritonavir 3TC simplification strategy by Jose Rivas. These are studies addressing switches in virological suppressed patients. I'm not talking about all the new stuff that you will be seeing here in Glasgow this week. So this is only switches. So the field, as you can see, is pretty active. So coming to the end, I can tell you that general principles of switching apply everywhere, which is true, but we need to take into account the caveat that these studies are done in very clean and adherent patients, not necessarily reflecting our real clinical practice that we see every day. Patients in clinical practice, they have a lot of issues that our very, very beautiful selected patients in clinical trials don't have. Our patients, they get pregnant, some of them use drugs, some of them have binge drinking, some of them use other medications. They don't come week 4, week 8, week 12 for having a viral load, et cetera, so we need to be careful again with that. So, reasons for switching. Well, as I said, to improve adherence, to reduce pill burden, there's a list, and probably we could add more arguments, but you need to take into account if your patients really want to switch, or there's a strong medical reason to offer switching. Have you preserved the potency? Again, this is a more important message of my talk. Is your patient a patient that has no history of previous failure or archival resistant? Has the patient undetectable viral load for at least 6 months? Have you considered potential drug interactions with other medications your patient might be taking? Is your recommendation cost effective? If so, you can switch. So thank you very much, and I want to acknowledge people from which either they gave me the slides or I just stole it. Thank you very much.